Good morning, friends. I think we are five of us. So let's start right in time, because a good start is always better than. So I'll request Dr. Ranjan to introduce, because first talk is from my side only. So please. Okay.
So good morning, everyone. So first talk is by Dr. Dinesh Garg, who will give talk on work-related ocular injuries, industrial trauma. So, Dr. Dinesh, sir, please.
Good morning to all the dignitaries on the dais and off the dais. So let's start in right earnest. The first topic for today's session is work-related ocular injuries, and I come from a industrial city of Punjab, and we see a lot of these ocular injuries, and over a period of last almost more than 20 years, I've been dealing with all different types of penetrating trauma, and I would like to share my experience in ocular trauma. So worldwide there are about 55 million eye injuries believed to occur every year, leaving 1.5 million as blinds. Globally there are approximately 2 lakh open globe injuries with an estimate of 3.5 per lakh per year of perforating injuries. And most of these are work related, and they affect young adults in productive age group with economic consequences for the family, for themselves, as well as for the country. So various studies in India have reported an incidence of ocular trauma to be 1 to 5%. Amongst the total number of blinds, 1.2% is contributed by injuries, which is easily preventable. And the incidence, depending upon the occupation, mainly students, farmers and manual laborers, they constitute the major chunk which get affected. In addition, drivers, factory workers, they can be involved in roadside trauma and can be affected by the work-related injuries. So as per the BETTS classification, open globe injury can be a rupture, which is a full thickness wound of the eye wall caused by a impact of blunt trauma, or a laceration, which is effect of a sharp object. It can be a penetrating injury, which is a single laceration, or a perforating injury, which is 2 full thickness perforations or through and through with an entry and exit wound, and it may or may not be associated with a retained intraocular foreign body. So a penetrating trauma, globe laceration, usually you will see some kind of a dark spot or a streak on the sclera and a jelly-like material coming out of the eye onto the face. And if you have any doubts, assume that trauma to the orbital area involves the globe. So it can be industrial, it can be a roadside accident, and these are one of the few surgical emergencies in ophthalmology and needs to be repaired at the earliest. So one should have a very high index of suspicion for a retention of foreign body, especially if you are able to see an entry wound. The foreign body may be lodged in the AC, lens, iris, or at the vitreous and retina. So there can be a double perforation leading to the foreign body going through the posterior sclera into the orbit. So in our center, we studied 7 patients of open globe injuries who underwent surgical repair at our place. And this was a retrospective study. And based on this, various factors which we evaluated to predict the outcome of open globe injury were the mechanism of injury, preoperative visual acuity, time lag between injury and surgery, and size and location of the wound. Other parameters which can predict visual outcome are whether this injury is associated with retinal detachment, uveal or retinal tissue prolapse, vitreous hemorrhage, lens damage, hyphema, presence or absence of retained intraocular foreign body, and how many number of procedures you had to do for these patients. So we divided these people based on the visual acuity, best corrected visual acuity at last follow-up, and the presenting visual acuity into 6 different groups. Group 1, 2, 3 were the people who were presenting with a good visual acuity or a visual acuity of anything up to 660, and 4, 5, 6 were with the poor visual acuity even up to the level of no PL. So we included no PL patients also in this, and as you all know, even a person who has doubtful perception or no perception of light at presentation may ultimately end up with some kind of a vision or sometimes even a good vision after interventions or after surgeries. Sometimes even out of scare, especially in children, they may not be cooperative enough to give you the right visual acuity perception. So various factors which you study were age of the patient, initial visual acuity, evidence of infection or inflammation, vitreous or uveal prolapse, vitreous loss, lens status, and presence or absence of retained foreign body. And at last follow-up, BCVA and anatomical status was recorded. So preoperative investigations usually included X-ray orbits, ultrasound, and CT scan. And we nowadays rely more on the CT scan findings. So out of the 70 patients, mostly these were males, and there were 3 patients who presented with no PL visual acuity. And as you can see from the chart, we started with only 9 patients with 6.6 or 6.18 visual acuity, and ended up with 25 patients with a good postoperative last follow-up visual acuity. Similarly, there were 11 patients who had endophthalmitis at presentation, and still out of these patients, a few of these got good visual acuity. At least 50% of those we were able to salvage. Lens rupture and cataract presence or dislocation of lens was there in 43 of these patients, and they also improved quite a bit with the intervention. Similarly, the uveal prolapse was there in 13. Retinal detachment and vitreous hemorrhage was there in 28. And again, after multiple surgeries, few of these, they ended up with good vision, and especially these 9 patients in a visual acuity range of 6.6 to 6.18. Yeah.
Please sum up, sir.
Sorry?
Please sum up, sir. Your time is.
Yeah. So foreign bodies were 54, and these are a few of these foreign bodies. And I have a couple of videos which I think for the paucity of time I will skip, just to show that these are the few patients which may end up with very good vision at the end. So I will not go through these in detail. So this we have already discussed. These kind of signboards should be there in all industrial places to prevent, and all out efforts should be done to prevent the visual the injuries. To conclude, a lack of good information system on injury burden, its pattern and impact prove a barrier to injury prevention. Occupational health policy was one of the components of national health policy. However, still very little attention have been paid to mitigate the effects of occupational diseases, and awareness and attitude of workers and employers towards safety norms are partly responsible for low compliance. Thanks a lot. Thanks a lot for your patience.
Very good study, I think, in industrial area. So one thing that in your study, out of 70 patients, only one female is
Yes,
there.
sir.
So is it related to their less number of female is working in industry, or any other reason that you have less number of female patient?
No, that's what I'm saying. Most of the times the males are more affected by especially the penetrating injury or severe injury, because The most common cause is either industrial or a roadside accident, even farmers and some students, drivers. So these occupations mostly are dominated by males. Of course, these can be with the females as well. And the other thing might be that females mostly they work in unorganized sector. So they may not come with the kind of a ESI cover or something, and the employer may settle this without being referred to a VR specialist or a tertiary care center. So awareness is a must, and coverage of industrial employees is also an issue.
So which type of foreign body you got in these injuries?
Sorry?
Which type of foreign body you got most of?
More of these were iron foreign bodies or a metallic foreign body lodged inside the vitreous or sometimes into the retina.
Besides the coverage, you had already shown thickly posted on the most
Yes, sir.
of the industries. I would just suggest that, especially with the ASI, because obviously all the workers usually come to the ASI.
Yes, ma'am.
For government purpose. I would just suggest if it is possible in your area, you can talk to the ASI people and at least get that reinforced to give them safety precautions to be reinforced.
Yes, ma'am, we keep doing. The only problem comes with is basically like in spite of our insistence, and especially so in the organized industrial sector, the awareness amongst the employees is very less. Even if these safety glasses have been provided by the employer, they will not use while working. They feel that it hampers their view or something, and they don't even know when something is going to hit their eye, and they'll end up in trouble.
That nobody can predict when
Yes,
it's going to hit their
yes.
eyes. So.
Okay. Okay.
the
Thank you,
next
sir.
speaker-
Thank you, sir. The next speaker is Dr. Rakhi Kushumes, and she will talk on update on medical management of ocular surface squamous neoplasia.
Good morning, everyone. First of all, I would like to thank AIOC for giving me this opportunity. So, I'll be talking about topical chemotherapies for OSSN. I have no financial disclosures. So, before going into the management part, I would like you to take through the basic concepts of OSSN. OSSN is actually a ocular surface squamous neoplasia, which is a spectrum of diseases from dysplasia to squamous cell carcinoma. And its diagnosis is quite clinical. You can easily pick these lesions on the slit lamp examination by finding conjunctival mass in the interpalpebral area in majority of the cases, and with some peculiar features and its pattern. So feeder vessels, intrinsic vessels are commonly seen with these lesions. And among the stain, rose Bengal stain is one of the stain which give you a good demarcation of the tumor line. The presence of keratin plaque is another very important feature of these lesions. One test I would always prefer doing in majority of the cases, particularly when I want to start topical therapy, and that is scleral fixity. It gives me an idea that whether the tumor is penetrating in the sclera or it is movable or just in a very early stage. So other than clinical examination, the gold standard for diagnosis of these lesions is the histopathological examination after excisional or incisional biopsy. Then non-invasive methods like impression cytology, but it gives very unpredictable results. UBM just to rule out any intraocular extension. And one most valuable tool for these lesion is spectral domain OCT, which gives you an idea of abrupt changes in epithelium and depth of the tumor. And especially when you are treating these patients with topical drugs, then it gives you really a good monitoring system. CT scan, when you suspect that there is a metastasis or extension of the tumor, then you should get the CT scan of the eye as well as the adjacent area. Now come to the management. We have two options, surgery or the medical management. Yes, surgery is a gold standard therapy for all the OSSN, irrespective of the cause and size, with wide surgical excision, with cryotherapy, and with or without adjunctive metabolites. If there is positive margin comes on histopathological examination, the chances of recurrence rate is very high. And in large tumors, it may cause limbal stem cell deficiency, scarring, and symblepharon formation. So here comes the role of topical therapy, which is fairly common nowadays. People are using it. This gives a few advantages over surgical management, like it avoids stem cell deficiency. It can treat a large area at one time. You can titrate with the concentration, and it can be repeated. So when to give these drugs, there can be used in various forms, like you can use for the reduction of the tumor, or you can use it as a prophylactic after surgical management, or as a prevention in a prophylactic period. So I prefer these topical drugs in cases of dysplasia and carcinoma in situ. In SCC, except when the patient is not suitable for the surgery, or if the lesion is multifocal, I want to reduce the size of the tumor before the surgery, I would prefer these drugs. Otherwise, I would straight away go for the surgery. So these are few indications when the tumor is recurrent, multifocal, involving the pupillary axis. These drugs are quite useful. So in our armamentarium, we have three main drugs: topical mitomycin C, interferon alpha 2b, and 5-fluorouracil. And other than that, there are many drugs documented in the literature, but of variable results. So one of the most ocular-friendly drug is interferon alpha 2b. It's a glycoprotein, and it has both antiviral and anti-tumor property. And it gives success rate 80% to 100% depending upon the the type of tumor. So this is the case of SCC. We actually done impression cytology in this case and found this result, and it was multifocal, involving the whole ocular surface and limbus. So this case responded very well to the topical interferon, and complete resolution was found within 3 months. Another case of gelatinous tumor with the pigmentation, and here also we got good results, and the whole tumor resolved within 3 months with few stippled pigmentation left over the surface. This is a case of leukoplakic. In leukoplakic OSSN, basically they respond very slow to any topical drugs, particularly interferon. They respond slightly faster to MMC, but you may need surgery in these cases. So we did a study on topical interferon alpha 2b as a single therapy for primary OSSN, and we found very good results. 91.6% cases responded to this, except few SCC and mucoid cases. So another therapy we have topical mitomycin C. It is little more toxic than the interferon, and it can be used as a primary or adjuvant therapy. It gives also 90 to 100% success rate depending upon the pattern of tumor. So it's a faster drug than interferon, and it takes less time to resolve the tumor. But it is not very ocular friendly. Every patient would have complained something in the eye, foreign body sensation, to epithelial defect. So we compared both interferon and mitomycin as a primary therapy in primary OSSN, and we found that the success rate was comparable in both the groups, but the time period which MMC had taken was relatively statistically significantly less in comparison to interferon. And as far as adverse reaction is concerned, then all patients of MMC had some or other reaction in the eye, while interferon was really very friendly. Another drug is topical 5-fluorouracil. It is as toxic as MMC, but it gives very good response in the tumor, and within 2 months you can find the good response in these drugs. So these are few pictures which responded very well to the topical therapy. And now during topical therapy we need to assess a few important
Please sum up, ma'am.
yeah. Few important things during the course of treatment, and it's very important to see that whether the tumor is responding to your treatment or not. So if there is any change in the size, regression in the height, or regression in the vascularization, then continue the therapy. Otherwise stop the therapy and plan for the surgical management. And you can have resolution complete, partial, and there may not be any reduction. Recurrence may be present at the same site or different site after completion of therapy, and depending upon the drug you can find the ocular reaction, and you have to choose your drug accordingly. So there are some criteria on which you can choose your drug depending upon the size of lesion, its morphology, whether gelatinous, papillomatous or leukoplakic, and what is the status of ocular surface. If the surface is dry, not very well, then don't go for mitomycin or 5-fluorouracil kind of therapy. Cost is another factor, and patient should be very compliant if you are going to start topical therapy in these patients and follow up. So these are the drugs, upcoming drugs, or people are using nowadays very frequently, and it's a viable option in the treatment of OSSN, either as a primary treatment or as a part of chemo reduction or as a prophylactic after the surgery. Thank you so much.
Thank you, Dr. Rakhi. What is your experience regarding cases of, like you mentioned about certain cases of SCC, so you've never tried that in SCCs, only in carcinoma in situ?
No, we tried. We tried the first case I shown, which was treated with topical interferon. It was a case of SCC with multifocal appearance involving the fornices also. But the point is, SCC with good height and large tumor, they actually don't respond to any drug, neither interferon or mitomycin or fluorouracil. But the lesion is flat, involving the limbus, gelatinous kind of lesion, they respond very well to any treatment, any topical treatment.
Especially regarding mitomycin, I just wanted to know, if you put the patient on topical, have you seen any scleral melts or kind of a complication?
I have not
sometimes they will not be compliant, and they
Yes.
just keep using that drug.
Yes, that is, it's very important thing to see whether the patient is compliant or not. Sometimes people have been put on this drug, topical treatment, and they keep using it and forgot for the follow-up part. So when they come after 2 or 3 months, either they have a very red or toxic eye, or the size of tumor has been increased a lot. So it's very important to keep the patient under follow-up, and mitomycin I have not experienced any scleral melt in topical mitomycin as per my experience, but yes, it gives a very toxic ocular surface, and you have to start sometime loteprednol in along with mitomycin C2.
Varying the doses also of mitomycin C in cases when they're not responding. Have
Yes,
you
I
tried
have
increasing
done.
the dose?
I have done. I have usually I give 0.04%, but in some cases I started 0.02%, but 0.02% I don't think so it's work.
For carcinoma in situ?
Yeah, it can displace. Yes.
Cases of cases which are still like
Yeah.
radiation cytology for every case before you start
Yes,
the treatment.
it can. For dysplastic early cases or carcinoma in situ, it can, if the size of a small tumor is small and relatively flat, we can use mitomycin C at lower concentration, just to avoid ocular toxicity.
So what is usual regimen for mitomycin C in such type of cases?
Mitomycin C I use 0.04%. Nowadays, I am not using mitomycin C at all, because I see more of complication rather than some good response from the patients. So 1 week off and 1 week on mitomycin, and I usually start low dose surface steroid along with the topical mitomycin C. But in case of interferon, I don't find any complication, and gelatinous tumor are the tumors which 100% respond to these therapies.
So in interferon also you take 1 week off and on and.
No, no, interferon you can give continuously without any complications. Sometimes patient feel little bit of conjunctivitis follicular, otherwise they don't get any kind of ocular side effect. It's very
Cost
good drug.
difference? Cost difference?
Cost difference is quite significant. Interferon, the whole therapy actually take around 3,000 to 4,000 or up to 5,000 rupees. Mitomycin is very cheap drug.
But you will give those, you will reconstitute those drops and give them, or?
Interferon, you can give multiple concentration, but preferably 1 million international unit. And it comes, one vial has 3 million international units. So you have to dilute 1 ml with the 2 ml of saline or distilled water.
Because mitomycin usually the 10 ml vial.
Yeah, mitomycin comes in a powder form and you have to reconstitute it with 5 ml of distilled water.
People started using mitomycin post-operatively to avoid, to prevent recurrent pterygium. But then these scleral melts and these things were common. Even in trabeculectomies, you find a
Yes.
lot of, late bleb leaks and all that. So mitomycin is a drug which is very toxic and continues to affect the
And
the
patients
tissues
are
on
not
a longer
compliant
term.
with mitomycin because
Yes.
they don't feel comfortable after putting the drops.
Yeah.
Only thing is cost factor.
Yes,
That
cost is
very
important. The better to
significant.
go for surgery rather than putting them on
So is there
mitomycin C.
any condition in which you directly put patient on surgery rather than putting first the chemotherapy
Suppose,
and then go for
first
surgery?
of all, if suppose I am treating, I'm not, I don't treat now leukoplakic with topical or any tumor which has a great height like mucoepidermoid or it's looking like SCC, then I don't go for topical therapy except in cases when the patient is not fit for surgery immediately and we want some chemo reduction or just for the time being. Otherwise, what did you ask?
Directly go for surgery without
Yes,
putting the
yes. So
patient
in
on
these
chemo
cases,
reduction.
I go for the surgery, or in cases suppose gelatinous is there, flat tumor involving the whole limbal stem cell, then I go for straight away go for topical. If patient cannot afford the treatment, suppose topical interferon, in these cases you can also go for 5-FU, which is one of the cheapest drug, 5-FU, and mitomycin C for 1 month or 2 months with topical steroids. Other than that, all tumors has to be surgically excised.
Okay. Thank you, Dr. Rakhi, for this is nice talk.
For recurrences, what is your experience for recurrences after surgical recurrences? Like
After surgical excision,
have you tried
recurrences
doing it
are.
after surgical recurrences using interferon again.
Depend upon the type of recurrence you have. Sometimes patient usually comes with the large bony tumor or big tumors. Then you cannot rely on the topical only. But here, my 2 or 3 patients who has xeroderma pigmentosa or recurrence at the same site or other site, small tumors have recurred, then these tumors can be treated with the same drug, even topical interferon, or in case you require MMC, you can also give MMC for at least 6 to 8 weeks. Till 6 to 8 weeks, it doesn't cause much, problematic, but after that, if you're prolonging the treatment, then mitomycin C actually make the surface worse even for the surgery. That's a problem.
Thank you.
Okay, thank you. Our next speaker
Thank
is
you, sir.
Dr. Vinita Gupta.
Just a sec. Because this was supposed to be a case presentation which was allotted to me, and my PG was supposed to present it. So I have already discussed with the scientific committee team. So much postgraduate resident would be presenting this instead of me.
Okay.
So Dr. Sneha, just come over. She'll be presenting this case.
Okay, so this topic is herpes zoster ophthalmicus in right eye with necrotizing fasciitis prescribed by trauma.
Good morning, everyone. The title of my case report is varicella zoster reactivation
Varicella zoster reactivation manifesting as PUK and deciform keratitis triggered after necrotizing fasciitis in an immunocompromised male. Starting with the introduction, herpes zoster is a prevalent viral disease that affects 20 to 30% of the population.
Slides भी move नहीं हो रही.
Your topic is changed, no?
No, topic is not changed.
Yeah, it is.
Written is like
Topic is the
maybe
same.
heading is something
Yeah.
different. Herpes zoster ophthalmicus.
Yeah.
बस register same with PUK. Okay. चले.
नहीं trauma.
सेम है टॉपिक उसको थोड़ा डिटेल करके लिख दिया
करके
है
लिखा है,
बस द हेडिंग हैज बीन मेड मोर डिटेल्ड इट्स द सेम
नहीं, it is written
It
herpes
refers
zoster
इट्स द
ophthalmicus.
सेम केस
Right eye with necrotizing fasciitis
Yes.
precipitated by trauma. Trauma is nowhere in the topic.
you will see it in the description we have just changed the title of the thing the case is the same case
You cannot change the topic, na?
it's not a topic change it's a case presentation sir it's the same case
It's
please
not,
listen.
it's not a competitive session, so let's continue with this, please. Yeah, that's fine.
Yeah, with
That's
the
fine, I
different-
think. Let's
title has
continue
been-
with this.
It's a
Title
more-
has been refreshed, I think.
yeah more detailed title has been given.
That's fine. That's fine. I think let's continue with this.
Herpes zoster is a prevalent viral disease that affects 20 to 30% of the population, and at some point in their lifetime, 20 to 20% of these individuals will have herpes zoster ophthalmicus, which can lead to significant visual impairment in the absence of prompt preventive antiviral therapy. And necrotizing fasciitis is a rare infection which spreads rapidly along subcutaneous soft tissue planes, usually involving the extremities, and only 10% involve the head and neck. Outcome depends on prompt recognition and early treatment. Starting with my history, a 45-year-old male presented with sudden painful diminution of vision with associated redness and photophobia in right eye for 2 weeks. There was no history of any vesicular rash and neuralgic pain, and there were no any complaints in left eye. There was also history of pulmonary tuberculosis which was treated, and the patient was under treatment for chronic deep vein thrombosis. There was also history of fall from stairs 1 month back, following which there was serosanguinous discharge from right eyelid, head and neck region with discoloration of surrounding area, which was diagnosed as necrotizing fasciitis. On culture and sensitivity, Staph aureus growth was seen, and surgical debridement was done along with broad spectrum antibiotics. Upon examination, we can appreciate a non-marginal upper lid defects measuring about 5 by 8 centimeter with multiple linear contracture scars involving right upper lid, temple region, preauricular region and the neck area, which led to incomplete closure of eyelid and exposure of cornea. The best corrected visual acuity in the right eye was 2 by 60 and in left eye it was 6 by 6. Upon anterior segment examination, we can appreciate corneal ring infiltrates extending from 3 o'clock to 7 o'clock position with dish-shaped central stromal edema, central epithelial defects and few keratic precipitates. Reduced corneal sensations were seen and posterior segment examination was unremarkable. Patient was evaluated for viral provisionally patient was diagnosed as PUK with deciform keratitis, and patient was evaluated further for viral infection, immunological disease and corneal scraping was sent for gram stain, KOH and Zang smear and PCR analysis. Side by side patient was started on eye drop prednisolone, eye drop atropine and fortified tobramycin and lubricants. Upon follow-up, worsening clinical picture. Upon follow-up, worsening clinical picture was seen with increasing corneal edema and Descemet membrane folds could be seen, and there was increasing ring infiltrate. And the autoimmune profile which was sent earlier revealed positive RA factor and positive ANA. And the herpes zoster DNA was detected in PCR sample. So patient was diagnosed as herpetic deciform keratitis and was started on oral acyclovir, eye ointment acyclovir, eye drop prednisolone, eye drop atropine and fortified tobramycin and lubricants were continued. Therapeutic bandage contact lens was applied, and on close monitoring, patient showed healing epithelial defects with decreasing stromal edema and ring infiltrates. A right paramedian upper lid flap reconstruction was done for the contracted scar involving the defect. Upon 6-week follow-up, total healing of epithelial defect was there and no sign of stromal infiltrates was present. We can see healed corneal nebular scar, and upper lid flap was remodeled for gaining upper lid excursion. On 2-year follow-up, patient is maintaining lid closure with best corrected visual acuity of 6 by 36 in right eye. Now, moving on with the discussion, herpes zoster is in approximately 50% of patients can lead to significant ocular morbidity and visual impairment in the absence of prompt preventive antiviral therapy. Calhoun et al. Reported ocular manifestations of herpes zoster as adnexal involvement, anterior uveitis, keratitis with corneal hypoesthesia, oculomotor nerve palsy, and optic neuritis with optic disc edema. Corneal involvement included stromal keratitis in 15.6% of patients, epithelial keratitis in 9.8% of patients, and concomitant superficial and stromal keratitis in 5.8% of the patients. Necrotizing fasciitis, as we have discussed, is a rare infection which spreads along subcutaneous soft tissue planes, usually involving extremities, abdominal wall, and groin. 10% involve head and neck, and involvement of eyelid is the rarest. However, eyelid skin is thin with little subcutaneous tissue fat, so necrosis following infection becomes quickly visible. Pattern of infections associated with periorbital NF is different due to high vascularity of the lids. Necrotizing fasciitis is divided into two types on the basis of microbiological culture, type 1 and type 2. Type 1 is a polymicrobial type caused by both aerobic and anaerobic organisms, and it is mostly seen in trauma and immunocompromised patients, and it is rare in periorbital region. Type 2 NF is caused mostly by single organisms such as streptococci or staphylococci or a combination of both, and it is not seen in immunodeficient patients. Presentation of necrotizing fasciitis can be acute periorbital swelling associated with severe pain, erythema of necrotic skin, further extensive subcutaneous involvement, and fluid-filled bullae, which may be confused as herpes zoster ophthalmicus. Wright et al. Reported a case of subacute necrotizing fasciitis of posterior neck, which disguised as herpes zoster infection. Associations can be, there are several case reports of systemic NF following herpes zoster infection, but very few papers have described association of periorbital necrotizing fasciitis with herpes zoster ophthalmicus. Necrotizing fasciitis after herpes zoster. Fung et al. Described periorbital NF in a 63-year-old female with discoid lupus who developed necrotizing fasciitis following cutaneous herpes zoster infection. Kozupoli et al. Described periocular necrotizing fasciitis following shingles in a 70-year-old female with Waldenstrom macroglobulinemia, and there was history of herpetic keratitis. Saldana et al. Reported a case of 59-year male who developed herpes zoster ophthalmicus, and 3 days later he developed periorbital cellulitis which extended to his chest region. Now, case report of herpes zoster after systemic NF. Ha et al. Reported presentation of herpes zoster triggered after necrotizing fasciitis in a 74-year-old male, but the herpes zoster presented as radicular pain with bullae involving the left upper extremity. In our case, herpes zoster was seen after periocular necrotizing fasciitis. Patient presented with peripheral ulcerative keratitis and deciform keratitis, which was seen as a sign of reactivation of herpes zoster triggered after necrotizing fasciitis. There was no history of precedent rash on the forehead, eyelid, and tip of the nose, no sign of previous zoster rash, no characteristic neuralgic pain, or any atrophic hypopigmented scars was there. Bilateral herpetic simplex keratitis can masquerade as peripheral ulcerative keratitis, especially in patients with immune system dysregulation, which can lead to
sum up, please. Your time is
which can lead to diagnostic dilemma, as reported by Pradew et al. In a case of 47-year-old female with history of arthritis and positive ANA factor. Now, the case highlights are herpes zoster manifesting as PUK and deciform PK activated after NF in a seropositive RA patient. Herpes zoster in our case was triggered by surgical debridement of necrotizing fasciitis. So, concluding, reactivation of herpes zoster ophthalmicus can present as corneal involvement without any precedent neuralgia or characteristic herpetic rash as first manifestation of reactivation of varicella zoster virus, and can masquerade as microbial keratitis. Hence, a high suspicion of herpes zoster reactivation should be kept in mind while evaluating for keratitis with negative microbial scrapings in an immunocompromised patient. These are my references. Thank you.
so nice case. Just go to the clinical picture of the patient.
Can we discuss at the end, because I think
Okay,
there is a shortage of time.
Okay, sure.
So let's go to the next talk, please.
So the next speaker is Dr. Vandana Kumari. Is she here?
Is the speaker there?
Dr. Vandana Kumari? I think she is not here. So we'll go with the move to the next talk. by Dr. Daisy Rani Das. Yeah, she will talk on corneal surface tattooing using platinum chloride and hydrazine hydrate, our experience.
DC. Yeah. कौन सा है? Next slide. ये वाला. Warm good morning to all of you, and I really thank All India AIOC for giving me this opportunity to speak a few words on this is a very old procedure which is being done since ages, and I just wanted to share my experience of using platinum chloride and hydrogen hydrate for tattooing the corneal surface. No financial interests. So as we know, it is a very age-old practice of covering the scarred cornea with black pigments in order to take care of the cosmetic disfigurement following the scarring. It was first introduced as early as 2000 years back by Gallen. So it is basically done to mask corneal opacities or any white reflexes in the eye, in eyes with low or nil visual potential, and also in a seeing eye it can be done to reduce glare and visual disturbances associated with pupillary and iris defects. So with the advent of time, as the techniques and the surgical instruments have been developing with the advancement of technology, better and improved ways of covering the corneal surface with pigments have been devised. So commonly it can be done in cases of corneal scars or adherent leukomas, iris defects, in unpleasant strabismic diplopia and Urey-Zavalia syndrome. And stains used are mostly metallic stains like gold and platinum. Non-metallic stains like India ink and lamp blanc ink have also been used, and even organic dyes have been used for tattooing. Different procedures are available like surface tattooing, stromal punctures, intrastromal lamellar dissections, and even femto laser assisted tattooing surgery. So in my case, I am just doing it as a surface procedure. I select, we had 7 eyes of 7 patients within a period, via time period of 1 year. After a thorough examination, including a posterior segment ultrasound, and patients were mostly interested for cosmetic correction of their unsightly scar. So we had various categories of patients. Most of them had PL absent or doubtful PL. One of the patients, he was a case of previous multiple keratoplasties. Even I had done he was a case of complicated cataract surgery followed by scarred corneal decompensation and aphakia, and then I took him up for optical PK, and then later on he developed a graft infection, and then we had to again take him up for a therapeutic PK later on, and following secondary glaucoma and other complications of keratoplasty, he had finally a PL absent eye, and he was finally interested for cosmetic correction, and we took him up for this tattooing procedure. Another case, she was a young female with a history of corneal trauma in childhood, and she was left with a non-seeing eye with a white cornea. Most of the cases, as we can say, are mostly following trauma, for scarring following corneal trauma. One case had multiple VIA surgeries too, and he had this white reflex in the center. We had to take him up for a partial tattooing involving only the scarred area. So, and all of them were not, few of them were not interested for cosmetic contact lens use, and 2 of them had intolerance actually. So patients were nicely explained about the aim of doing the surgery, that it is only for cosmetic reasons and not for any kind of visual gain. We did the surgeries under topical anesthesia. The dyes, as we have already mentioned, it is 2% platinum chloride and 2% hydrogen hydrate. Unfortunately, I could not retrieve the video, so I've just written the steps here. That after a proper sterile procedure, protocol was maintained, the topical anesthesia was instilled and the corneal epithelium was scraped. After drying the cornea with a sponge, we used 2% platinum chloride solution, which was soaked in filter paper and placed for 2 minutes. Following this, the 2% hydrogen hydrate solution was used, which was actually the reducing agent. After 30 seconds of use, we removed the filter paper and we waited for 1 or 2. It takes some time to the color takes time to get developed, and slowly the color changes. As we know, platinum chloride is a yellowish a powder. After we have to dilute it, make it a percentage of 2%, it becomes a yellowish solution, and upon reducing with hydrogen hydrate, it turns into blackish color. So after that, the surface is rinsed with lingalactate, and I place a BCL over the surface, and then in the next post-operative day, I usually put plain antibiotic drops for 4 times a day for 2 weeks, and then 1 drop of atropine at bedtime for 3 days to reduce the pain. Also, oral analgesic tablets are used for 2 days. And then after 48 hours or so, I usually remove the BCL after ensuring epithelial healing, and we start on topical steroid drops after we taper dose over 3 weeks. Patient satisfaction, we usually assess in front of a mirror, and then most of the patients had very good response in terms of satisfaction. None of the patients had any intraoperative or postoperative complication, and no additional staining. But these are some of the pictures which I had taken for the patients. As we can see, the post-operative picture, the cosmetic part has been taken care of. This is the patient with multiple keratoplasties, which undergone almost the center part was very much thinned out. It was not appropriate to go for an intrastromal or lamellar tattooing procedure. Sorry.
Please sum up.
Yeah. So we can just skip to this is the one with the partial tattooing. So as we can see, only problem is in case of a colored iris, like low light colored iris, it would be difficult to match the color, because this agent, platinum chloride and hydrogen hydrate, only gives us a black color. So some of the studies done previously showed some of the complications, like some needed a restaining, some had some kind of toxic effects like granulomatous keratitis or uveitis. So as we know that it of course gives a satisfactory result in terms of cosmesis in eye, absolute eyes, both, as well as in eyes with some degree of vision, but with problems like glare or due to iris defects or dilated pupil. So we can go for this technique in more. I mean, we can have this technique as a routine, as a regular procedure, because even the cost factor is not much high. So other than this corneal surface tattooing, we also have intrastromal and or lamellar techniques where we can use directly inject dye in the corneal stroma for getting the desired results. Thank you so much for your patient hearing.
Thank you.
Thank you, sir.
So how many days, what is the duration of a stay? Like once you do the tattooing, how many months it stays there?
So mostly we have followed up the case till up to now. We have been seeing them for up to 6 months. There has no fading or requirement of re-tattooing. They usually say up to 3-4 years the color is always as good as the it is acceptable, but maybe over a period of 8 to 10 years they may get faded up because it is a surface procedure. That's the thing.
So So from where you procure all these dyes?
So this we procured from Chennai. There is a pharmaceutical company, Chandanmal. We directly talked to them and they provided us over by courier.
Okay. So is there any difference in doing this procedure on post-keratoplasty eye and in normal corneal scar dye?
Sorry, sir.
Is there any difference in doing procedure or outcome in doing the normal, like after trauma you get a scar and did, and in failed keratoplasty cases you did?
No, sir, not really, not really. If the corneal thickness, everything is, we just have to take care, there should be no, we have to take care of the perforation part. We should not go, the scraping has to be really done gently on the areas of thinned out, so where suppose previous melt has happened. So those areas we have to be a little bit careful. Otherwise, it's same for both categories of corneas.
I think we'll thank the speakers. If Dr. Vandana Kumari is there.
Thank you, sir.
Her name? No. So, thank you. We have finished well in time. And can we have a pic of all the participants and the chairpersons and the speakers, please?
Thank you, Monica, for being with us.